Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege. Today, we're talking to Dr. Richard Watson, Dr. Martin Sellberg, and Dallan Huff from Motient about patient movement. Let's dive right in. Hey, Dr. Dan.
Hey, Faisel. How are you?
It's good to see you. Dallan, it's good to see you again.
Yeah, very good to see you.
I'm so glad that you helped to get everyone together for this podcast episode. Who would have thought that people just getting together and talking about healthcare would turn into like the 2022 version of like the old-fashioned AM talk radio. Dr. Watson, Dr. Sellberg, it's so nice to meet you both. I'm Faisel Syed. This is Dr. Dan McCarter. We are very passionate about educating young residents and physicians about the transition from fee-for-service towards value. I got connected with Dallan just within the last couple of weeks. I love your story. I would love to hear about, if you could talk a little bit about the situation in Kansas. What was the drive behind creating this organization? Dr. Watson.
Yeah, well, I'll pick that one up. I think originally that the idea came from Dr. Sellberg, and I'll just tout his horn a little bit here, that he saw a long time working with rural hospitals and trying to understand the motivations that move people from one place to another. A lot of times they were one-offs. A lot of times they were fairly random decisions. A lot of times they weren't well matched with the resources needed. And I think it created just a huge opportunity to say, can we give them a tool to help them be able to judge not only where they should go in the system, but also by what method they should go. This whole idea of air versus ground, a real problem in some locales. And I think with the dollars associated with that sort of a decision, and a lot of times it being made very randomly at times by people who were not always thinking about the patient's needs or certainly the patient's responsibilities, it drove to a place where he developed an acuity index. This was a way to index the severity of the patient's condition, the risk of deterioration during transport, and then what happens, what will they need in the future. Amazingly, then, that tool proved very, very useful in kind of defining the boundaries of what that looked like. And from there, then we put, the software wizardry behind it and all of that. I think there's a lot of logistics programs, a lot of what everybody would call Uber-esque, moving people around. But this was more centered on, can we better match the patient needs with the mode of transport and the destination, and then how do we fold all those individual conversations into a place where people can actively see and use the material.
Yeah, we see this all the time in med. There are only so many hospital beds, first of all, and so many times you'll see people are in a particular hospital that they didn't need to be in that, say, like level 1 trauma center. They could easily be managed down the street at another hospital. Open up that hospital bed for someone who really needs that level of care.
Yeah, I mean, I think interestingly enough, even in the last month, we've had more conversations about what would be once called repatriating patients backwards in the system. And I think this idea of lateral movements in the system, acute bed to acute bed, never really had a need until we started to realize that resources were just being chewed up left and right. And could we exchange high acuity patients in tertiary or quaternary centers for lower acuity patients that could go back to their home base, actually recover better in their home locale, while all the time we're utilizing resources better. The problem's always been reimbursement. No one's ever incentivized that sort of behavior, either from a hospital basis or you get down to a transport basis. How would local EMS, and I mean, this is a huge topic here of the number of deadhead transports that go backwards with no patient inside the vehicle that can easily be repurposed for moving people if there's a logistic infrastructure to be able to do that. And again, that was the brainchild, I think, of Dr. Sellberg and how he put it together.
Can I ask a quick question? We just jumped right into the conversation, and it's great. Can somebody give us just an overview of what Motient does? It sounds like we're talking about strategies, and I would love to know what sort of who you serve and how you serve them. Dallan?
Yeah, I can get into that. I think at its core, we're a patient movement company, and we primarily focus on interfacility emergent uh, patient movement. We help hospitals, health systems, ACOs, the like, to essentially, as Dr. Watson said, match patients both with the right mode of transportation, but also the right destination. We're our product, Mission Control, is a software as a service product, so it's entirely web based, and it really has three components. There's the requesting functionality that incorporates the acuity index that Dr. Watson so eloquently described just a minute ago. That really helps to determine, how sick the patient is and what their likelihood of deterioration during transport would be. After that acuity score is developed, we have a logistics platform that allows the sending hospital, the receiving hospital, as well as the transport company to interact together to really coordinate, what's going to be the best way to move that patient. Once the transport is complete, on the back end, we have a very robust real-time data platform that allows everybody involved, from the sending facility, the receiving facility, as well as the transport company, to view data that's fit for purpose for them, to help understand how patients are moving within the system, how vendors are performing, and different things that can really help them to improve that patient movement process. Dr. Watson, I think, has eloquently coined the phrase that if we can manage the movement of patients in the system, we can manage the system. And I think, said another way, if we can transform the movement of patients in the system, we can transform the system. So at its core, that's what we're trying to do. Our first set of customers were in the state of Kansas. In late 2020, we signed a contract with the Kansas Department of Health and Environment to make the software available to every hospital in the state. And then over the course of 2021, we onboarded most of the Kansas facilities. So we have over 110 facilities in the state that are utilizing our services today. And then, along with kind of our core capabilities that come with Mission Control, we also incorporated what we call our bed finder capability, where this really kind of sprung out of a need from the pandemic. We essentially monitor the capacity in all of the hospitals in Kansas, as well as some of the surrounding states, to really help find beds and make sure that we can get patients to where they need to be to receive the care that they're in need of.
We offer transportation within a 10-mile radius around our offices. So I think most of us with cars and in pretty good health, we don't think, 5 miles or 10 miles is not a big deal. But if you don't have a car, or you have heart failure and you can't walk more than, say, 100 or 150 yards, transportation really impacts healthcare. And if you don't get the right patient in the right transportation, it gets very expensive very quickly. So I've got to applaud you for doing this. It's important work, but a lot of times the important work doesn't look terribly sexy, but it's really important.
Absolutely, and I think as we've ventured further into this, and especially our experience in the state of Kansas, I think what we've really come to understand, probably even more so than when we started, is just the power that comes in understanding how patients are moving in the system. And we think of systems in different ways at times, but that could be at the entire state level, or it could be within a group of affiliated hospitals, or even a group of unaffiliated hospitals. And I feel like we've been able to help manage that movement in a variety of different ways. And most of it comes from the data that we're able to see to help people to make better decisions on how to move those patients around.